2015 in San Francisco for On the Scene, and with me is Tomohiko Taniguchi from Japan. Dr. Taniguchi has a very interesting study that may have far-reaching clinical consequences. So I'm going to ask you about this aortic stenosis study and ask you what the study was about to start with and then how you did it. So why did you do the study?
So our current guidelines recommend the watchful rating for AVR until symptoms emerge in asymptomatic patients with severe AS. However, this recommendation was based on previous small single-center studies evaluating the symptoms or AVR, but not mortality as outcome measures. And there is no previous large-scale multi-center study comparing the initial AVR strategy with the conservative strategy. So we therefore designed the current AS registry.
Okay, so this is a registry, retrospective, not randomized, in asymptomatic patients with aortic stenosis, split between two major groups: interventional therapy, that is surgery, versus conservative therapy, medication. Okay, interesting study, very important just in terms of how we deal with these patients. Asymptomatic patients, I should once again say. Tell me what you found.
So our asymptomatic patients were 1,808 patients, and we divided two groups, the initial AVR group and the conservative group. And the baseline characteristics and the entire cohort were significantly different between the two groups. So, for example, our patients in the conservative group were much older, so 78 years old and 72 years old, and had higher STS score, 3.5% and 2%, and more often had comorbidities such as prior strokes or coronary artery disease. So we developed a propensity score match cohort of 582 patients as the main set analysis. And we compared the clinical outcomes of the two groups, and the cumulative 5-year incidence of all-cause death was significantly lower in the initial AVR group than in the conservative group. And hazard ratio was 0.64. And the cumulative 5-year incidence of heart failure hospitalization was also significantly lower in the initial AVR group than in the conservative group. Hazard ratio was 0.19.
Okay, so the propensity scoring that you did obviously allowed you to put a little bit better comparison groups together, and you ended up having significant differences between the two, AVR group being far better in clinical outcomes. So as you look as what this study may mean to all the viewers out there and the clinicians out there with patients with asymptomatic aortic stenosis, what do you think they should do?
So from our data, among 1,570 patients of the conservative group, 492 patients became symptomatic during the follow-up, and the NIH-3 and NIH class 4 heart failure was seen in 40% of these patients. And if you look at the AVR rate, AVR was less frequently performed in patients who presented with NIH class 3 and class 4 as the initial symptoms related to AS than in patients who presented with NIH class 2. So probably from these data, some of the patients were not referred to AVR because of their clinically bad conditions. So probably the long-term clinical outcome of asymptomatic patients with severe AS was dismal when managed conservatively, so which might be substantially improved by the initial AVR strategy.
All right, I remember when I was a cardiology fellow, we learned that aortic stenosis was not a good thing to have, and mortality was high as soon as symptoms occurred. Now we have asymptomatic patients, and we learned that in fact being aggressive in even asymptomatic patients with aortic stenosis is an important part of taking care of them and having good outcomes. Thank you very much.
Thank you.